okey ni. 90 MB. Okay. Okay, slide.
Boleh kau buka Google? Kau tak buka. Try hot Google dulu.
Mana tu lah?
Gmail. PDF kita tak buat keluar. Tak letakkan luar.
Reporter. Ni.
Buka je. Buka. YouTube dulu. Share. Ni Chrome tab ni.
Ni PowerPoint.
Chrome tab.
Nak kan ni?
Tak ada.
Slide. Slide. Tapi tak boleh full screen. Kau
tak keluar.
tak habis lagi dah. Dia hujung lah.
Tak keluar. Tak boleh PDF.
Mana jalan topik lah ni. Kalau Pediatric apa?
PowerPoint.
Okay. Tak jadi pun.
Cuba video.
Hashtag.
Sebab itu tengah baca yang atas.
Kau naik lah itu.
Stop sharing.
Apa?
Sekejap tapi tu boleh tak PDF ni minggu sebab tu.
Oh, kena buka dulu.
Stop sharing. Ni buka dulu.
Ada audio?
Ada. Tak ada. PDF tak ada.
Tu tak habis lagi tu.
Terus sekali.
Cepat ni. Lah, minggu depan hari tu. Tu jadi PowerPoint. Sekali lagi PowerPoint dah.
Tapi kan PowerPoint dia lain.
Resolution dia kan.
Buat kat Google Slide. Cuba tekan.
Kita tekan lagi dah. Buat berapa poin. Lah. ni dia ni. Mana? Ni kita ingat. Jadi. Nampak guna kamera ada ni.
Tak ada buat rekod Google Slide.
Kalau ni okey macam tu. Boleh lah dah. Nak apa kata kan? Kita tengok. PowerPoint. So, apa dia tak silap cantik.
You cannot use Google Slide. This one is
This one,
PowerPoint.
okay, but it seems okay.
Okay.
Yeah.
I'm afraid the audio. I mean, you had some animation.
No. Just the transition only, no video. Yeah. So I think okay.
Yeah.
Yeah.
So your live also. Okay.
Okay. Yeah.
Assalamualaikum warahmatullahi wabarakatuh dan selamat pagi kepada semua yang hadir pada hari ini, terutamanya kepada para tetamu kehormat kita yang berusaha Dr. Putri Marbaya binti Muhammad Ismail di Badan Perkara Perubatan 1, yang berusaha Dr. Lahana binti Muhammad Fazil di Badan Perkara Perubatan 2, Ketua Jabatan, Pakar dan Pegawai Perubatan, Paramedik dan seluruh kakitangan Hrpz yang dihormati. Pertama sekali, saya ingin mengucapkan ribuan terima kasih kepada semua kerana sudi meluangkan masa bersama untuk menghadiri sesi CME kita pada hari ini. Saya, Dr. Salsabila daripada Jabatan Pediatrik akan menjadi pengacara anda pada hari ini. Untuk kehadiran, sila imbas kod QR yang dipaparkan di skrin. Kod QR juga tersedia di kedua-dua sisi dinding dan pintu auditorium. Tanpa melengahkan masa, saya ingin menjemput Dr. Sharanya Giridharan untuk menyampaikan CME hari ini dengan tajuk Tuberculosis in Children dengan segala hormat yang dipersilakan.
Terima kasih pengerusi majlis. Selamat pagi semua. Nama saya Dr. Sharanya. Please allow me to speak in English. So I'm a pediatrician here and currently pursuing pediatric infectious disease. Today, I will be talking about tuberculosis in children. This is a very big topic, so I hope to give an overview and mainly focusing on how we can close the diagnostic gap. The outline of my slides will include a little bit of epidemiology, risk factors, the differences of tuberculosis in children and adults. We'll go through some case scenarios, looking at how they present, what is the approach, the challenges, the treatments, and the outcome. Okay, my presentation today is in line in conjunction with the World Tuberculosis Day, which falls on 24th of March every year. The reason it falls on this day is because of this German physician, Dr. Robert Koch. Okay, he contributed greatly to tuberculosis, where he actually identified the Mycobacterium tuberculosis, and he presented his findings on 24th of March in 1882 in Berlin. The hard facts about tuberculosis is that TB is the world's leading cause of death from a single infectious agent. It is among the top 10 causes of death. In 2024, there were 10.7 million cases of TB worldwide, out of which 1.2 million were children. And there was 1.23 million deaths from TB in 2024. So TB, contrary to common belief, it is present in all countries and in all ages, from babies just a few days old to the geriatric age group in 80s and 90s. So we heard that there was 1.2 million children who were affected with TB. Out of these, 174,000 of them, there were deaths, among those less than 15 years old. And the majority of them, more than 50%, were less than 5 years old. Okay, these numbers are probably much smaller than the actual number because TB is often overlooked in children. It is widely underdiagnosed or underreported in many countries. And it's sad because TB is actually preventable and a curable disease. Okay? So when we look at the world map, there are 8 countries which have the highest number of TB cases. Fortunately, our country is not in this list. Okay, so the highest being India, which has more than 2 million cases per year, followed by other countries in the Southeast Asia, Indonesia, Philippines, Bangladesh, China, Pakistan, and many parts of Africa. So where does Malaysia stand Okay, Malaysia is in the intermediate threat, a moderate to severe threat for TB. Considering the size of our country, which is quite small, we have a significant number of TB cases, which is about 300 to 499 per 100,000 population per year. What is the current situation in Malaysia? We've been hearing a lot about TB on social media and in the news. The fact is that TB cases in the country are rising. Okay, there is a cumulative of more than 3,000 cases already for this year. Okay, and the highest number of TB cases are in Sabah, Selangor, and Sarawak. This graph compares the number of cases in every state from 2015, 2020, and 2025. Okay, in 2025, we had a total number of 26,672 cases. So this is a significant rise compared to 2020 and 2015. But 2020, we know there was COVID, so cases were generally less than usual in many states. Okay, and for Kelantan, we had a total of 999 cases last year. This is less than the previous years, so that is reassuring. Okay, for pediatric cases, however, there was a total of 1,603 children with TB in 2025. Okay, this is increasing from the previous year. And in general, the pediatric cases, the incidence is about 6% for our Malaysian statistics out of all TB cases. And for Kelantan, we have 32 cases last year, which was increasing from the previous year, which contributes about 3.2% of the total number of TB cases in Kelantan. Okay, so the highest number of cases come from Kota Baru, Pasir Mas, and Tumpat. And the high-risk groups are those who are more than 65, smokers, and those with diabetes as well. So it's important to screen these groups because children are often hiding somewhere in the household among a lot of family members, and they are often overlooked. So when we look at the number of, when we look at the age group, we had total of, as mentioned, we had total of 32 cases last year. So the majority falls below 5 years old. Okay, so if we see here, out of the 32, 17 were actually less than 5. And this is what's happening in many places as well. TB is, in children is more prevalent in those less than 5. So when we go back in time, we look at the history of tuberculosis. It's actually existed since the 17th century, but it was not named as tuberculosis. They knew of this disease and they wrote about it in, even the Egyptians wrote about it in the 17th century. And then in the 18th century, they wrote about it in medical literature. And then in 1834, the term was coined. The tuberculosis term was coined. And we know in 1882, Dr. Robert Koch identified the causative organism, which is Mycobacterium tuberculosis. So, and then in 1907, the Mantoux test was formed. Okay, so this is just to depict that this is a painting that was drawn in the 18th century by the painter who had TB himself. Okay, so moving forward to today, we know more about this organism, and it's also known as Koch's bacillus after the scientists who identified it. It is now identified with acid-fast stains, mainly zeolnison and auramine, and it is highly aerobic, requiring high levels of oxygen, which is why it thrives in the lung. And it can withstand weak disinfectants, can survive on dry surface area for weeks, and it spreads by droplet inhalation. And humans are the only known reservoir for MTB. What happens inside? So when we come in contact with someone who has tuberculosis, we inhale the bacilli, and then it travels through our nasal cavities and it goes down into our lungs, into our airways and then our lungs. And then it sits in the terminal alveoli, where it is ingested by alveolar macrophages. The host immune response releases all the immune cells, bringing more cells to that area, resulting in the formation of a granuloma. So in adults, this granuloma with the bacilli inside can remain dormant for many years. However, in children, they can rupture and they will result in the spread of bacteria to the lymph nodes, to the blood vessels, and it can spread anywhere in the body within 2 years. Highest risk is 6 months to 2 years for children. So then it can spread to basically everywhere: the brain, meninges, eye, lymph node, bone, pleura, skin, the gastrointestinal, and the urogenital tract. So in the risk factors in general, we know if we have close contact, either a family member or a friend, even if we're spending a long time at work, then a colleague, living in crowded areas, those who are working in healthcare like us, those with limited access to healthcare, those staying in rural areas, children, those who are immunocompromised with HIV, cancer, those who are not vaccinated against BCG, the homeless population, those with alcohol and drug abuse, malnutrition, diabetes, elderly, and those on immunosuppressants. So in children, the high risk group are those with a younger age group. As the younger the age, the higher the risk of TB, and the higher the risk for dissemination, which means a more severe TB. Because of their weaker immune system, they're not able to fight the infection. So the next group is the orang asli group, because they're staying very far away, and they lack access to proper roads, proper healthcare. They have no financial means. Okay, usually they are not vaccinated as well, especially against BCG, and this puts them at high risk. Usually, when they come in, they come in late, and it is usually a disseminated form. Okay, other than that, children who have chronic illnesses, those who are premature or have chronic lung disease, those with immunodeficiency, malnutrition, HIV, malignancy, and those who are attending hostel and boarding school. And among teenagers as well, teenagers have a wide social circle, and they tend to spread and have tuberculosis similar to the adult type. Okay, let's go to some case scenarios. So we have the first case, which is NA, a 2-year-old Malay girl who was referred from KK Teluk Jering. She was relatively well. She did not have any cough, fever, or night sweats, and her growth was appropriate for her age after we looked at the growth charts. Regarding her history of TB contact, her father was recently diagnosed with pleural TB and started on treatment. On clinical examination, it was normal. So proceeded with this test for latent TB screening, which is MEN2, which was negative, only 1 mm, and her chest X-ray, which was normal. Okay, so this is her chest X-ray, which is relatively normal. Okay, and then upon looking back into the father's history, when we traced his culture results, we found that it was resistant to isoniazid and streptomycin. And then we further looked into what was his treatment, and found that his treatment was actually changed to rifampicin, levofloxacin, pyrazinamide, and ethambutol. So hence, this child was started on rifampicin for 4 months and remains asymptomatic. So the diagnosis is latent TB infection. So it's important here to, when you're getting the history of TB contact, to get more history regarding probably when it was diagnosed, what is the type, whether there was a revision in the treatment, and whether if you can, try to look at the MTB-CNS results as well. So this was the DATS result. Okay, so for latent TB, it means that the children are infected with TB bacteria, but they do not have the active TB disease yet. So usually they are asymptomatic and well. They have a positive history of contact with TB, and they may have a positive TB blood test, which is known as AGRA, or MAN2, or it may be negative as well. And they will have a normal chest X-ray, and if performed, usually they have negative sputum results as well. So this is important that these children are started on TB preventive treatment, because as mentioned, in children, it can progress to an infection from within 6 months to 2 years. Okay, and the progression is more common in those with a younger age group. Okay, so the second case, Nam, a 3-year-old girl, presented with to KK Gunung with chronic cough for 1 year. She had poor appetite and poor weight gain. So when we asked further history, it was found that her grandfather was recently diagnosed with smear positive pulmonary TB. On examination, she had cervical lymphadenopathy and reduced breath sounds over the right upper zone. So proceed with the testing, which is MAN2, but it came back negative. Gastric lavage was done for her because she's unable to expectorate sputum. So there was no AFP in 3 samples, and gene expert was sent, which was not detected, and MTB cultures was taken, but the results are pending. So this is her chest X-ray, which shows right hilar lymphadenopathy. You can see where the arrow is there. And there's also paratracheal lymph node enlargement with interstitial air space opacities and peribronchial cuffing as well. So she was started on the 4-drug anti-TB regime with involving the FDC, which is the dispersible combination type, given syrup ethambutol and syrup pyridoxine. It was notified, and we liaised with the KK as well to make sure she was compliant with DOTS therapy, which is directly observed, and then arranged for her to see us back again with repeated liver function tests, and also arrange for ophthal screening whenever we start on ethambutol. It is necessary to refer to ophthal as well. So the diagnosis in this patient is smear negative pulmonary tuberculosis. So if we look back, you can see the only positive sign was the history of contact. She had chronic cough, but all her tests were negative. And she had however, her chest X-ray was suggestive. So in children, the tests often come back negative. Okay, so as mentioned earlier, the children who are less than 5, they are higher risk for rapid spread. And infants and younger children, they are more likely to develop severe forms of TB, TB meningitis, disseminated TB, miliary TB disease. Okay, and this has a very high mortality. And TB in children is underdiagnosed and underreported in many countries. So the reason the tests come back negative is because of the paucibacillary nature, which means that there's less bacilli, but because they have a weaker immune system, it can still spread and cause severe disease in them. So the tests often come back negative. And without treatment, the TB disease is deadly. So the mortality rate for those who are less than 5 without treatment is thought to be up to 43%. And those who have been treated, the mortality rate is 0.9% only. So there's a very big difference. Okay, let's look at the third case scenario, which is quite a complicated case. So this is MA, 11-year-old Malay girl. She was referred from Hospital Malacca. She presented in September with amenorrhea, which is lack of menses, and abdominal distension for 5 months. So she was admitted there. She was started on antibiotics, okay, and a CT scan was done because she had abdominal mass. So it showed findings of ascites, okay, multiple lymphadenopathy with peritoneal carcinomatosis. And she also had very high tumor markers. Okay, so, and then she was referred to PET surgical team. Initially, they were thinking of malignancy. However, on further history, she'd been having recurrent fever since January, which is already 9 months from the time she presented. And then she had lower abdominal pain. She had loss of weight. Okay, she lost 10 kilos and loss of appetite. She was not going to school, not ambulating much. And then there was history of contact. TB lymph node in her paternal grandmother, whereby already completed treatment. However, later on, after she came here and she was diagnosed, then we found out actually her uncle also recently diagnosed as TB. Okay, so there in Malacca, they proceeded with peritoneal drainage, which they sent for gene expert, which came back negative, and MTB culture was also negative. So this is her CT scan. You can see that there is augmental caking with where the arrows are, and there's also a large amount of SITs. Okay, so for her sputum, we also sent her sputum, which was negative, and then we sent stool for her, which was negative as well. However, her MAN2 and her IGRA was positive. Her hormonal workup was normal. So hence the diagnosis of peritoneal TB was made. She was discharged there because they were planning to relocate to Kelantan, and then she was given an appointment to our clinic here. So, however, the day before she was supposed to admit, as the day she was supposed to come to the follow-up, she was admitted, and she had high-grade fever with drenching night sweats and abdominal pain. So on examination, she was cachexic, had multiple cervical and inguinal lymphadenopathy. There was generalized tenderness with ascites and voluntary guarding. There was a diffuse mass as well over her lower abdomen. In ward, she was admitted and started on antibiotics and also started on anti-TB medications. So initially, her ultrasound showed similar as the CT findings. And then 2 weeks later, 2 weeks after her anti-TB, there was slight improvement, reduction in the ascites. However, she continued to have fever at this point and poor weight gain. Okay, so but however, before discharge, she was already afebrile, and there was a reduction in the ascites and the collection. And she was seen about 3 weeks later in the clinic. During this time, she had no weight gain, but no more fever, and her pain was less. At this point, she was already almost finishing her second month of intensive course of anti-TB, so it was extended to 3 months. Okay, so we saw her last yesterday, and whereby the pelvic fluid had already resolved in January, but yesterday we noted that she has good weight gain, she's already going to school, she's a completely different person. So if you can see, her symptoms started in January last year, and it took 1 year for her to get better. Okay, so in children, it can be very vague, the symptoms for extrapulmonary TB, and it's important to have a high index of suspicion, especially in our country where TB is endemic. Okay, so let's look at how to approach TB in children. Okay, so we know that the diagnosis of TB in children can be challenging because the collection of sputum is usually very difficult. Only children more than 5 years old are able to expectorate, and that may be difficult as well. So in children, it is recommended we take gastric lavage samples with Rouse tube insertion, where it may be a limitation in certain rural clinics. Okay, and these lab tests, they often come back, even when they are taken, they often come back negative. And this is because, as mentioned earlier, of the paucibacillary nature. Negative tests, however, does not mean that there is no disease. And the symptoms may overlap with other common pediatric illness, especially for pulmonary TB. It may be diagnosed as recurrent pneumonia. Okay, so it's important to remember that the workup may be negative, but there may be other factors pointing to TB disease, and it's our responsibility to pick them up. That means looking at the symptoms, arranging additional tests if necessary, especially when there's an abnormal chest X-ray and when there is TB contact. Okay, so how do we get a history of TB contact? Okay, so as mentioned earlier, we know the hotspots. Okay, it's important to identify wherever you are, the hotspots in your area where there are higher number of cases, and also look at the household, how how many people are living there, how many adults and children, is there crowding, do they have close friends who are always coming over to the house, what are the occupation of the adults, do they have exposure to foreign workers, is there history of prolonged cough among everyone, any admissions for lung infection or unexpected deaths that may suggest MDR TB, or whether there was multiple, if there was contact, were there multiple or prolonged causes of treatment? And if you can identify the contacts, look back at their notes and have a look at their culture results as well. So it's not as simple as, ada orang sakit TB tak kat rumah. So you really have to ask more. Okay, so the symptoms of TB, usually it affects the TB most commonly affects the lungs. So in pulmonary TB, they have prolonged cough. They can have lymph node enlargement, whether it's the cervical lymph nodes, inguinal, or in the lung that will be seen on the X-ray. Okay, and they have fever, night sweats, and failure to thrive is a very important symptom and a sign, and which is commonly overlooked. Okay, and for extrapulmonary TB, as we heard the case earlier, it can be more difficult, where they can present with a wide range of non-specific symptoms. Okay, so when we look at the growth chart, what are we looking for exactly? We have to identify not just one weight, meaning the weight when we are seeing the patient. We should look back at the growth chart, look at a few readings, and look at whether they are crossing the centiles. When you see like from their normal centile, they move into the next less centile. Okay, or whether there's an acute loss of weight, which would suggest an acute illness. Okay. So what do we know about the BCG vaccine? Okay, the BCG vaccine is actually invented in 1921. It is actually an attenuated, which means weakened live strain of Mycobacterium bovis, and it is given intradermally over the right upper arm. So that's where we should look for the scar. Okay, and it is very effective in preventing miliary TB and tuberculous meningitis. So it is also thought to be helpful in pulmonary TB, where in various studies they say it can be protective up to 60%. And it is also thought to be protective against leprosy. The side effects, however, are BCG lymphadenitis and disseminated BCG infection. Usually, disseminated BCG infection occurs in children with HIV or those with immunodeficiency syndrome. Okay. The clinical syndromes of pulmonary TB in children, usually they involve the lung tissue, they can involve the airways or the draining lymph nodes. So you can see the various syndromes in the picture here. And it's important to remember that it should be clinically diagnosed as well, not necessarily bacteriologically confirmed. And the symptoms already mentioned: persistent prolonged cough, poor weight gain, weight loss, suspicious chest X-ray. So TB is usually hiding behind diagnoses like a recurrent pneumonia or failure to thrive, malnutrition. Okay. For extrapulmonary TB, they can spread in many systems. It can occur in the CNS, which is commonly seen in younger age group, and symptoms are non-specific. Okay, and the other systems that can be involved are pleural, musculoskeletal. So we have a patient currently in the Anggrek ward who is an Orang Asli boy. He's about 9 years old and he's admitted for TB spine. Okay, his symptoms also started quite rather long, since for about 4 to 5 months, where he had back pain, unable to walk, and he actually had history of going back and forth to the KK, was admitted to the hospital and only able to diagnose after many months. Okay, and he has quite a severe, extensive type of TB spine. Okay, so the other system, as mentioned, the oral cavity, cutaneous, GI, and genitourinary tract as well. Okay, in babies, as I mentioned earlier, babies can also have tuberculosis. So the congenital type is when it spreads from a mother who has active TB to the baby while in utero via the placenta, or it can spread shortly after birth when they ingest the infected fluids. So the symptom onset is usually within 3 weeks, and the symptoms also are quite vague. They can have poor weight gain or some sniffling, some cough, okay, and fever. And it's often overlooked as well. Okay, so in neonatal TB is the type when they are diagnosed postnatally, meaning the exposure occurred after birth, either from the mother or maybe some other household members. Okay. In children, in generally, we should do a thorough clinical examination whenever we are suspecting any illness, basically. So we should look at their growth parameters, plot their weight and height on appropriate growth chart, look at the trend, get their vital signs, examine for lymph nodes, not just in the cervical region, but everywhere. The axillary, the inguinal, look at the general health, examine the chest, look for deformities, listen, and look at the spine if you can, look for any gibbous formation or any other deformities. Examine the abdomen, check whether it's distended or there's hepatosplenomegaly, and remember that severe malnutrition is a grave sign. Okay, that means we're dealing with a chronic illness, and important to remember TB in these situations. Also examine the joints for any swellings. Okay, so the first test usually that we have and most commonly done and should easily available everywhere is chest X-ray. Okay, so for TB specifically, what are the signs? What are the signs that point towards TB? Would be enlarged lymph nodes or looking for consolidation or calcification. So in this chest X-ray 8B, you can see here there are arrows which shows the enlarged paratracheal lymph node with the Gons focus. Together they form the Gons complex. Okay, so in chest X-ray A, which is normal, you can see that the hilar region, there's the convex shape. However, in B, there's loss of this shape, and this is due to the enlarged perihilar lymph node. Okay, so this is also suggestive of tuberculosis. And it's quite non-specific as well. It could exist in pneumonia as well. Okay, so for this chest X-ray, you can see that there's enlarged paratracheal lymph node where the arrow is here, and enlarged perihilar lymph nodes. Okay, if you can do a lateral chest X-ray, it will be helpful. We need to look for what we call as the donut sign, which is the enlarged lymph nodes over here. Okay, here. So also look for whether there's a consolidation, and all these are suggestive of TB. So miliary TB is a very severe form of TB, which is a disseminated type. It tends to occur in the younger age group, less than 2 years, because it spreads very quickly in this age group. And why they call it as miliary is because that they have this less than 2 mm reticulonodular pattern, and it is generalized and spread evenly throughout the lung fields. And this is a very severe and high mortality rate. Okay, so the next test that should be done is the MEN2 test. So this test we saw that this test has existed already more than 100 years. So it will involve the intradermal injection, whereby it will stimulate a T cell mediated hypersensitivity response if you have previous exposure to Mycobacterium TB. So the reading is usually done 48 to 72 hours later. However, it's important to remember that if it is done too early after exposure, it may not mount a response. So if it is done after recent infection or any illness, because we're not able to mount, our immune system is rather weak, then it can come back negative as well. Okay, so for children, the cutoff value is 10 mm. Okay, and in those with HIV, then we take a lower measurement, which is 5 mm. Okay, so the sputum test that should be done. So it's important to remember that getting sputum from children is difficult, and we may need to be a bit resourceful how we can arrange this test. Okay, involving gastric lavage or either giving nap to get the sputum, or in certain situations then bronchoalveolar lavage. Okay, so the sputum should be sent for AFB, 3 samples, and MTB culture. The reason we send both together is because for AFB to come back positive, we need a large amount of bacilli per milliliter. It's about 500 to 1,000, 10,000, okay, bacilli to come back positive. However, for MTB culture, you only need 10 bacilli. Okay, so in children, we know it's very hard to get the bacilli. Okay, and other tests are newer tests like molecular tests. Gene expert also should be sent. It's very helpful in children. And other blood tests are like IGRA. Okay, it's usually not done in those who are less than 4. So if they are more than 4, you may consider in certain situations. And depending on availability as well, may not be available in some places. Other supportive tests are like ESR. Okay, so depending on each case, the test sent is different for extra-pulmonary tuberculosis, depending on the site involved. In general, for example, like a CNS TB, we may want to do imaging, CT MRI, arrange for lumbar puncture. Okay, genitourinary TB, maybe send urine and do scans as well. If we're dealing with TB lymphadenitis, then arrange for lymph node aspirate tissue culture or Z-Nielsen staining. Okay, and for musculoskeletal TB, bone and joint tissue. Okay, yeah. So all this image is taken from the CPG. If you have any further questions, you should look at the CPG as well. Okay, for children in general, we use a regime of 4 drugs. Okay, during the intensive phase for 2 months, and these are the drugs: isoniazid, rifampicin, pyrazinamide, and ethambutol. So it's important to make sure you have the correct weight, measure the weight during every follow-up, and optimize the dose. And make sure you don't exceed the maximum dose at the right-hand corner here. Okay, and whenever we've started treatment, we have to explain to the parents why we have to start 4 drugs, how should it be given, the importance of compliance. Okay, if they miss more than 14 days, then the whole regime has to be started again. Should liaise with the KK to get them to do dots as well, and arrange for repeated, make sure there is a baseline LFT and FPC, and repeat that after 2 weeks. And remember to also include pyridoxine. Okay, so 4 drugs during the intensive phase for 2 months, and 2 drugs during the maintenance phase, which is 4 months of isoniazid and rifampicin. Okay, so these are the principles of treatment. As mentioned earlier, we should calculate the accurate weight, okay, measure if we can, and optimize it during each follow-up. And we use 4 drugs in general for children, okay, and all these cases should be notified, and make sure we have opened the TB, filled out the necessary TB documents, open the TB wallet as well, and insist on compliance to the parent. Okay, identify a primary caretaker that should be in charge of giving the medications, and also get the KK involved, okay, to address any other issues. So if there's compliance issues, then can get back to us and may need to consider round tube insertion. Okay, treatment outcomes are excellent for those who complete treatment. As mentioned, the mortality rate comes down to only 0.9% for those who are treated. They will need follow-up for 2 years post completion of the anti-TB medication. Okay, so these are the side effects. for the TB drugs. So as we know, rifampicin, isoniazid, and pyrazinamide are hepatotoxic. So it's necessary to have a baseline liver function test and repeat this after 2 weeks. And isoniazid can cause peripheral neuropathy, so it should always be given with pyridoxine. And ethambutol can cause optic neuritis, so always arrange for Oftal to do a visual assessment. Okay, for extrapulmonary TB treatment, the duration of treatment, it varies according to the site involved, and this is also not fixed. It may be extended beyond what is stated here, depending on case-by-case basis. Okay, and corticosteroids should be used for tuberculous meningitis and TB pericarditis. Okay, for latent TB treatment, there are multiple regimes, but in general, we use there are 3 main regimes that we use, which is 3 months of isoniazid rifampicin, or 6 months of isoniazid, or 4 months of rifampicin. Okay, it will depend on the age and also whether they have any underlying illness as well. Okay, so now that we have available in most places, which is the FDC, where they've already formulated the 3 drugs into a tablet, okay, which is rifampicin, isoniazid, and pyrazinamide. And this is slightly more palatable, making it easier for children to take it, and easily mixed, easily dissolved in water. And these are the doses. So however, we don't have the continuation phase 1. We only have the intensive phase 1. And you also need to add on ethambutol and pyridoxine apart from this. Okay, so these are the guidelines that you should refer to for TB in children. Okay, and so I'm coming to the end of my talk. I would just like to talk about this NTB goal, which was created. It was started in 2014 by WHO, and it's also in line with the SDG developmental goals. Okay, and the goal is to reduce the number of deaths from TB to 95%, to end the TB epidemic, okay, by 2035. Okay, so I'd like to end my talk today by showing you this picture of this tuberculosis ward in Pulau Jerejak in Penang, which was built in the 1930s, but during the British colonization. So now it's almost 2026. It's already 2026. It's almost 100 years later, and we are still dealing with TB. Okay, so it's important to actively work together between the hospital, the public health, and the primary care physicians to actively screen those high-risk groups so that we can identify all the children who are at risk and initiate treatment. Okay, thank you.
Terima kasih Dr. Sharanya atas pemberitaan yang very informatif sebentar tadi. Kita kini membuka ruang dan peluang daripada para hadirin untuk mengemukakan sebarang soalan. Jika ada, boleh angkat tangan. Kalau tak ada, Dr. Sharanya nak tanya ni. Tak ada. Kalau macam tu, Dr. kita proceed dengan quiz. Ada.
Especially in sleeping TB, latent TB. Bagaimana kita tahu after we complete the treatment, the TB kita telah maksudnya sakit sudah bebas daripada kuman TB.
Okay, so for latent TB, selalunya dia orang tak ada simptom kan, cuma dia orang ada kontak. Dan so kita mulakan rawatan untuk prevent TB disease itu. So kita akan follow up untuk 2 tahun selepas. Setiap follow up pun kena tanya, tengok untuk examination, ada got any other signs or not, tengok dia punya weight, tengok kalau ada simptom kita buat chest x-ray, kita work up seperti biasa. Kalau if there are if we are suspecting TB in the latent TB group during follow-up, we have to rework up again. Meaning you send sputum investigations, you send the gene expert, and then you try to look for whether the child is having TB or is it like, are we dealing with other diagnosis? Okay, and we follow them up for 2 years. And if we see that they are thriving well, developmentally appropriate, systemic examination is normal, then that's a reassuring sign.
So it means after 2 years, maksudnya kita boleh consider free from TB punya maksudnya.
Yes, ideally waktu rawatan, lepas complete rawatan, TB cell tu akan dibunuh lah. So kita follow up untuk tengok waktu itu kalau ada apa-apa sign. So if there are no signs, then it's likely that the TB is treated. The latent TB infection is treated, provided they have to be compliant to the medications. Okay, pastikan dia orang ambil lah ubat tu.
TB vaccine is not 100% protective, it's not lifelong. So this means the role of vaccine for the data.
Okay.
Because they are increasing number now.
Yeah. So actually the BCG vaccine is thought to be protective only up to 10 years or so. However, there are many research now. They are doing on many countries are preparing their own vaccines. However, those are all still in clinical trial phase. Hopefully one day they are able to come up with a vaccine that can be given to adults as well.
Good morning, Doctor. I'm Hannah. I would like to ask regarding the contact tracing. If the person just exposed 2 to 3 days prior to the TB positive patient and then kita work out at that time, all negative, negative, CSV normal, no symptom, do we need to repeat the workup after the incubation period 2 to 3 weeks later?
It depends on whether they have symptoms or not. If they do not have symptoms, then we start them on the latent TB treatment as usual. However, we keep a close eye. Whenever they do have symptoms, then we have to repeat the workup. Yeah.
Okay, this is like a comment. I think problem utama kita sekarang ni, problem utama lah, masalah yang masih ada bagi kita sekarang ni adalah we underdiagnosed TB overall, especially in children. Okay? Kalau kita tengok data kita di Malaysia 6.2% of TB children compared to total numbers kan. Jadi kalau worldwide it's about 10%, 12%. Jadi kita ada tempat-tempat yang mana kita mungkin underdiagnosed TB. Kenapa? Apabila kita tadi susah nak diagnose TB children. Tapi salah satu perkara yang kita perlu kena stresskan ialah apa nama ni, bahawa kalau there must be high index of suspicion bila kita kanak-kanak bahawa itu TB. Contoh tadi kan ada kes yang nombor 2 tu 1 year of chronic cough. I'm sure that kali di klinik tapi nobody think of TB, probably just treated as a recurrent pneumonia. Jadi benda tu berlaku dalam komuniti kita bahawa kita lambat diagnose. Kita lambat diagnose datang banyak kali betul kan. So one of the way kita nampak ialah cara nak detect children, terutamanya satunya high index of suspicion bahawa any prolonged symptoms, budak tak growing, dia try semuanya, apart from the nutritional aspect, think about whether this could be TB and explore further. And issue about exploring ni, macam Dr. Sharanya sebut tadi lah, kalau ditanya ada sakit TB dalam family sebab majority will say no, majority will say no, but we have to explore. Kita banyak kali kes yang ada orang tua kat rumah yang baru diagnose TB. So kita diagnose TB kanak-kanak, dia cek balik memang ada TB. Dia tak pernah pergi klinik. Sebab apa? Sebab dia bedridden, malas nak pergi, patut dah lama. Okay, so it was detected. So we have to explore, be more investigative sikit, tanya soalan mengenai tektor kemungkinan ada TB. Sebab kita tahu di Kelantan ni, TB banyak yang ada. And second thing is TB contact tracing itu penting. And contact tracing. Okay, sebab bila kes TB, kalau kes TB kanak-kanak, when you have diagnosed TB kanak-kanak, meaning that there is an active transmission in our community. Okay, different from adult kan? Kalau adult mungkin jadi active transmission ataupun reactivation. Kan? Tapi children dia tak reactivate. Dia baru aktif tidak dapat TB dan dia primary progression. Okay, dapat TB jangkitan TB dan dia dapat TB manifestation of disease quickly. So if you diagnose TB in children ni, maksudnya ada seseorang yang memberikan kuman TB dalam community dia. Yang dalam kawasan berdekatan. So it's very important to look at it. So kalau kita diagnose TB in children, maksudnya ada adapter, biasanya adapter yang actually transmitting, ada di rumah ikut kebiasaannya ataupun dalam sekolah ke ataupun tempat-tempat lain. Dan so contact tracing, contact tracing kadang-kadang banyak kali kanak-kanak ni tertinggal daripada contact tracing. Mereka buat semua, tapi anak-anak kecil tak buat. Banyaklah faktor dia. Ada kecil tak buat X-ray, takut ambil darah, takut macam-macam. Okay, so we have to insist kalau ada if ada apa, kalau kita tahu berapa ramai yang ada contact tracing dan sebagainya, kita make sure everybody is being tested. Dan kalau kita consider risk pun, antara adult dengan kanak-kanak household contact, there is much higher risk for children to develop TB daripada older adults. So if kita tak cukup nak investigate semua contact tracing untuk family, untuk that family contohnya, do the children better than you do the adults. Because the yield is going to be much higher in children compared to adults. Fortunately at the moment it's reverse. Apabila kebanyakan children tak screen, tak pergi sekolah lah ataupun kecil lagi lah, mak dan bawa ke klinik dan sebagainya. So there are many factors that make it more difficult for children to screen, but we have to identify that and make sure that in that case, adult identifies TB, children semua contact tracing must be done, and all children must be screened in the family. Okay? And also the final thing is don't forget TB also has a stigma. TB ni ada stigma juga. Walaupun tak sebesar HIV, kan HIV kita tahu stigma, tapi TB disease pun ada stigma juga, kan? And that stigma can make it more difficult for us to diagnose TB. Sebab bila kita ada stigma, dia tak akan cerita pasal penyakit. Dan bila kita tanya soalan about konteks apa dia tak mengaku lah. Then recently we had a case where unfortunately the child died, 2 tahun kan, about 2 years old. Diagnosis tak lambat dalam waktu. Kenapa? Sebab dia deny any contact. Sampai tanya banyak kali dan X-ray show very strong evidence of pulmonary TB. Then dia kata, oh ya, ada seorang ada TB dalam family. Which made the difference if you know it from early and start the treatment early. So remember that there are also stigma dalam masyarakat kita mengenai TB. Kita rasa macam kita tak ada apa-apa kan. Tapi masyarakat kampung mungkin tak terima. Dia akan pulaukan family, kalau dia yang dijual kedai musik dan sebagainya, orang tak tahu kita dia. That's why dia tak nak cerita. Yang dia ada sama dengan anak, orang tahu, takut nanti dia susah nak ikut dalam komuniti tersebut. So be aware of our situation in our community. Thank you.
Thank you so much, Dr. Maliki, our consultant ID pediatrician. So I hand back the floor to Dr. Sharanya for the quiz.
Okay, so the first question is, all these questions are very easy and were repeated multiple times in my talk. Okay, first question, TB in children is most prevalent among which age group? Okay, you can see the answer there. A, B, C, or D? Anyone? Okay.
The answer is B.
Yes, correct. Okay, less than 5 years. Okay, next question. Which statement is true? Okay, A, TB in children only affects the lungs. B, TB tests in children are usually negative. C, children with latent TB infection do not treat treatment. And D, sputum tests should not be sent for children.
The answer is B.
Yes, correct. Okay, so last question. What is a positive mental test in children? Yes, correct. Okay, more than 10 mm. Okay, thank you very much.
Dengan habisnya kuis tadi, maka tamatlah kita punya CME pada hari ini. Dengan ini, saya ingin menjemput Dr. Putri Nurbaya binti Muhammad Ismail, Kepala Pengarah Perubatan 1 untuk menyampaikan sijil penghargaan kepada Dr. Sharanya pada hari ini. Terima kasih. Terima kasih doktor. Dengan itu, kita telah sampai ke penghujung sesi CME pada hari ini. CME seterusnya, Saving Life, Gaining Pahala, Ramadan Reflections for Frontliner from HMI akan diadakan pada minggu hadapan. Terima kasih semua. Assalamualaikum warahmatullahi wabarakatuh.
Bersamamu